In the interest of time, can I please invite Dr. Owais to teach us a few things about crafting in the Cath lab?
Thank you.
And to the presenters, kindly try to keep it in, finish in 5 to 7 minutes if possible. We have to leave this area for the next session at 15:45.
Assalamu alaikum wa rahmatullahi wa barakatuh, everyone. I am Dr. Owais from LUMS, Hyderabad, and just showing you the crafting, actually the hand crafting in the Cath lab. I was the second operator in that case, and along with Dr. Mohammad Kashif Sheikh Sahab. So my patient was a 50-year-old female. She was diabetic and hypertensive, presented with a CCS3 angina for 3 months, and she was on optimum anti-ischemic medication. This was the presenting ECG, which shows the LBB. The labs are within normal limits. Okay. Here they missed the echo slide actually. Echo was also within normal limit. The EF was of 50%. Then we took the patient to the Cath lab and did the coronary angiogram from right radial route with the Tiger catheter. In this, the circ was looking good, but there is a proximal LAD disease. The left main again is normal, and circ is again normal, but there is a proximal disease which is more evident in this view. You can see there is a severe disease in the proximal LAD, and the vessels is heavily calcified. The calcification here, you can see the severe disease in the proximal LAD. Rest of the LAD is normal. RCA is also normal, though no any disease in the RCA. So we plan to do the PCI to LAD and next day, because it was an elective case and because of the family decision, that's why approval, we decided to do the PCI very next day, loaded with the clopidogrel. So we did the PCI from femoral approach next day with EBU 3.5, 7 French guider. The Cougar XT wire was taken and passed through the lesion and parked in the distal LAD. We took another balloon and, we took another wire and parked in the distal diagonal. We pre-dilate the lesion with NC 2.75 into 15 up to 18 ATM. The pre-dilatation of the proximal LAD lesion. Then we deployed the Zines expedition of 2.75 into 33 mm and up to 12 ATM. These are the stent deployment clips. Then after post-stenting, these were the results. So stent was under-expanded. Then we, again, here you can also appreciate the under-expansion of the stent. Then we post-dilate the stent with NC 3.5 into 12 mm up to 20 ATM. But even after that, the stent was under-expanded. So we decided to take the larger balloon of 408 mm up to, and we did the post-dilatation with high pressure. So these were the results after post-dilatation, and the stent was well expanded, well apposed, and good flow. So this is the final angioplasty result of the left system, LAD. Then now, we shifted the patient now in the hemodynamically stable condition, the CCU, and post-PCI CT was 249. But just after 1 hour, we received a call from the CCU that patient dropped her blood pressure after shifting from the Cath lab and complaining of shoulder pain. Her oxygen saturation was 94. and she was profusely sweating. Then we urgently did the post-PCI ECG. This is the pre-PCI, post-PCI. There are some minimum ST elevations here, but rest of the ECG is okay, the same as previous. We started fluid boluses and with inotropic support and shift the patient to the cath lab on IV fluids, and the blood pressure was 75/50. And everybody can understand this was a very panic situation. Family was aggressive at that time, and we also. But when we relooked the angiogram, the stent was okay. The right system is also okay. So what could be the other reason? Then we decided to check the access site, and you can appreciate there is a needle stick injury which can be done by in any center by any fellow. So it is because the prick was a little bit higher than the usual position. So the inferior epigastric artery was perforated, and there is a extravasation type 3. So we did the manual compression of around in view that it might stopped, and we did the manual compression up to 30 minutes of 2 cycles, up to 1 hour. We did the manual compression, but when we released it, again the extravasation was persisted. The BP was 80/60 heart rate, and saturation dropped to 8, from 10 to 8. We arranged urgently 2 packed cells we transfused, and we applied pressure for 1 hour. In the meantime, we were doing all these things also. Then we decided to take the contralateral approach from the left femoral. So we, from JR4, we took the wire and crossed through these perforation site here. And we did the balloon tamponade here. We took a balloon and inflated here to seal the perforation. And we did the balloon tamponade of about for 20 minutes or more. But even after ballooning, when we release it, still the extravasation persisted. Now you can understand that this is a very panic situation. The patient was become hemodynamically unstable, family was aggressive, and we were all panic here in the cath lab. And here, unfortunately, we do not have no covered stent, no coils, no vascular surgeon were available in the cath lab.
Dr. Owais, your time is coming up. It's gone.
So we attempted to seal the puncture site with manually crafted. So we crafted the balloon manually in the cath lab. And how we crafted, we took a BMS stent here, and it take the balloon, inflate the balloon, and cut from both sides, and then we wire from the threads of the filaments of the coronary wire. And then we successfully manually crafted the stent, and we sealed the perforation successfully, you can see, and luckily the branch was also okay. We shipped the patient to ICU with no groin hematoma, nothing. Then on second post-procedure day, patient complaining of abdominal pain, constipation, audible gut sounds. We did the CT of the scan, and you can see there was a moderate retroperitoneal hemorrhage there that was causing pressure compression on the gut. We did the manual decompression of the gut, and on the 4th day, then after manual decompression, the retroperitoneal hemorrhage regressed, and patient discharged on the 4th post-operative day, hemodynamic stable condition. She is fine, asymptomatic with normal labs. Recent update, after these 2 years, then within the last 2 months before, we did the angiogram of the patient again because of recurrent chest pain and bradycardia, and it was nothing problem here. Stent was okay, and all the coronaries were also normal. Thank you so much.
It's safe to go through the right femoral again, because your inferior epigastric is already there with the covered stent, so no more risk of that.